Imagine looking in the mirror and seeing this mass growing on your nose.
Yeah, that's not a great thought.
Right, and we are not talking about like a small bump or a temporary blemish here. Picture a really dense, heavy growth that just slowly, relentlessly expands over a decade.
Just kind of taking over.
Exactly. It keeps growing until it's, maybe 7 centimeters across, which is roughly the size of a small lemon, just sitting squarely on your face.
It's intense.
And it's physically pressing down on your nostrils, making it a daily struggle to just breathe in and out. It interferes with how you eat, and obviously it completely crushes your self-confidence, right? It makes you want to just hide from the world.
Absolutely. The psychological toll is huge.
But then imagine walking into a medical clinic, staying completely awake in the chair, and having a doctor use a highly focused, intense beam of light, a surgical laser,
Right.
and they literally vaporize that mass away.
Yeah.
Layer by microscopic layer, they just carve the disease off and give you your face back.
It honestly sounds like pure science fiction, but it is a very real, very profound medical procedure. I mean, it changes lives overnight.
Welcome to today's deep dive. We are exploring this incredible intersection of life-changing cosmetic dermatology and the really intense high-stakes safety protocols of the operating room.
Yeah, there's a lot going on behind the scenes there.
For sure. So we are unpacking a severe, often misunderstood condition called Rhinophyma. We're going to see how it's cured with cutting-edge surgical lasers, and then, and this is the wild part, we are going to explore the surprising, hidden dangers that come with that cure.
And we have a fascinating stack of sources guiding our conversation today. We're pulling from a really detailed medical case report on a giant Rhinophyma.
Which is a crazy read.
It really is. We've also got clinical insights from top laser experts like Dr. H and Dr. Montero. Plus, we are diving into a highly specialized Australian clinical trial. It's known as the TH-RIVE study.
Right, the TH-RIVE study.
Yeah, which looks at laser safety in airway surgery. And we'll actually be cross-referencing all of that with a literal surgical fire safety training manual.
So let's start with the condition itself, Rhinophyma. Now, for most people listening, that word might not immediately ring a bell.
Probably not.
But the visual of a bulbous, enlarged nose is something you've likely seen. So what is biologically happening to the skin to cause a mass like that?
Well, to really understand Rhinophyma, we have to trace it back to its origin, which is rosacea.
Okay.
Most of us think of rosacea as just, a bit of facial flushing, maybe some chronic redness on the cheek.
Like getting rosy cheeks when you're embarrassed or hot.
Exactly. But Rhinophyma is what happens when a specific type of rosacea, Phymatous Rosacea, is just left untreated for years. The sebaceous glands, which are the tiny glands in your skin responsible for producing oil.
It's a sebum, right?
Yes, the sebum. They just go into absolute overdrive.
So wait, it's not a tumor. It's literally an overgrowth of these oil glands.
Yeah, exactly. And it triggers this really severe cascade. You have the chronic inflammation from the rosacea and these glands constantly pumping out excess oil.
Which sounds awful.
It is. Over years, this relentless inflammatory state causes fibrosis. And fibrosis is essentially just the thickening and scarring of connective tissue.
Oh, wow.
So the tissue on the lower half of the nose hardens and multiplies. The skin transforms into this really bulbous, pitted, uneven mass. Visually, you'll see widely dilated pores, continuous oil secretion, and sometimes even deep pustules.
That sounds incredibly painful. Who does this usually happen to?
It predominantly affects men over the age of 40, particularly those with fair skin.
We also need to pause here and address the historical baggage attached to this condition, because reading through this, society has not been kind to people with Rhinophyma.
No, not at all.
For decades, it's been casually referred to as, like, whiskey nose or gin blossom.
And that is one of the most harmful and stigmatizing misconceptions in dermatology. Rhinophyma is absolutely not caused by alcohol consumption.
It's just a complete myth.
Total myth. The medical literature is crystal clear on this. It is the end-stage result of untreated chronic rosacea, period.
Yeah. Wow.
Yet for generations, society just blamed these patients, assuming they were closet alcoholics. So on top of the immense physical deformity, these patients carried this massive, unfair burden of shame.
That psychological toll is just heartbreaking, but reading through the sources, the physical toll is honestly just as alarming. It isn't just about how the nose looks, right?
No, not at all.
A large Rhinophyma can physically destroy the function of the nose. The sources mention the collapse of the external nasal valve. How does that happen?
Well, think about the underlying architecture of your nose. The tip is entirely supported by relatively thin, delicate cartilage.
Right. It's pretty squishy.
Exactly. Now imagine attaching a heavy, dense weight like that 7-centimeter mass we talked about right onto
Wow.
that delicate cartilage. Gravity and just the sheer mass of the fibrotic tissue eventually overwhelm the structural integrity of the
It
nose.
just crushes it.
Basically, the cartilage buckles under the pressure. The nasal apertures, your nostrils, get compressed and severely deformed.
So the patient literally loses their airway.
They do. They really struggle to breathe, especially during exertion or while they're sleeping. It alters their speech, making them sound, chronically congested.
That sounds miserable.
It is. The mass can even hang down over the upper lip, making eating difficult. It becomes a systemic quality of life issue.
Which honestly makes a certain policy mentioned in the sources wildly frustrating.
Oh, the NHS policy.
Yes. In the UK, the NHS rarely covers the reshaping process for Rhinophyma. They largely categorize it as a cosmetic procedure unless the patient can prove it severely blocks their breathing.
Yeah, it highlights a major gray area in healthcare policy. Because the condition begins as a skin texture issue, rosacea, it kind of gets lumped into the cosmetic dermatology bucket.
Right.
The bureaucratic system really struggles to recognize when a cosmetic issue graduates into a functional disability.
I mean, wait, if a patient's nostril is structurally collapsing so they can't breathe or eat properly, how is that just a cosmetic issue? It's kind of like watching a slow-moving avalanche, right?
That's a good way to put it.
It starts as this little flurry of rosacea flushing, just some surface redness. But if you ignore it, it slowly snowballs, picking up mass and density over 10 or 15 years,
Exactly.
until it results in a total structural collapse of the entire nasal valve. You would never call digging someone out of a collapse building a cosmetic fix, but that's essentially what these doctors are having to do.
A very apt way to look at it. Because of that bureaucratic label, countless patients are just left stranded, forced to navigate private clinics to find relief out of pocket.
Which is so unfair.
It is. But the silver lining, however, is that for those who can access treatment, the medical technology has undergone a massive renaissance.
Yes. Let's talk about that fix, because reading about the historical treatments for this, I mean, they sound medieval.
Crude is probably the best word for the old methods. Traditionally, a surgeon would take a scalpel and just physically carve the thickened tissue away. Or they might use dermabrasion,
Which is what exactly?
essentially taking a specialized sanding tool to the nose.
Oh my gosh.
Yeah. And another common method was electrocautery, which uses a highly heated electrical probe to burn the tissue off.
But the nose is incredibly vascular, isn't it? It has a massive blood supply.
Oh, absolutely.
So if you take a scalpel to a giant inflamed mass of blood vessels, the bleeding must be nearly impossible to control.
That was the primary danger. Excessive bleeding completely obscured the surgical field. It made it incredibly hard for the surgeon to see what tissue was healthy and what was diseased.
I can imagine.
And with electrocautery, the issue was uncontrolled heat. You're trying to delicately sculpt a nose, but an electrical burn radiates heat deep into the healthy cartilage underneath.
So you're damaging the good stuff too.
Right. The collateral damage was severe. We're talking massive scarring, permanent loss of skin pigmentation, and sometimes permanent deformity of the underlying cartilage.
Enter the laser. The sources point to CO2 and erbium YAG lasers as the modern gold standard. We are talking about highly advanced, extremely powerful surgical devices.
Very powerful.
The sources specifically name models like the Luminous Ultrapulse Alpha and the Cyton Jewel X. So, how does a beam of light succeed where a physical blade fails?
It all comes down to a concept called precision ablation. And ablation simply means vaporization.
Okay.
The CO2 laser, for instance, emits a very specific wavelength of light, 10,600 nanometers. And this specific wavelength is highly absorbed by water.
And human skin cells are mostly made of water.
Precisely. So when that laser beam hits a skin cell in the rhinophyma, the water inside that single cell instantly boils.
It boils.
Yes.
Yeah.
It turns to steam so rapidly that the cell literally explodes and vaporizes. But it does this in just a fraction of a millimeter.
Oh, wow.
Yeah. The laser only penetrates a tiny, tightly controlled distance into the tissue.
So the surgeon has a microscopic level of control.
They do. They can sweep the laser across the nose and remove the mass layer by microscopic layer.
That's incredible.
And even better, as the laser vaporizes the tissue, the peripheral heat instantly seals the blood vessels. So there is virtually zero bleeding.
That solves the scalpel problem entirely.
Exactly. The surgeon has a perfectly clear, dry canvas to sculpt the nose back to its original anatomical baseline.
Literally sculpting with light. Let's look at the specific case report from the sources because it really brings this to life.
It's a great case.
We have a 67-year-old male patient. He had a 12-year history of rosacea that he hadn't been able to get treated, and it had progressed into this giant rhinophyma, a dark red lobulated mass on his nose measuring 7 by 6.1 by 4.5 centimeters.
This case perfectly illustrates why these modern laser techniques are so vital. Consider the patient profile. He is 67 years old and has a history of hypertension.
Right.
Putting a patient with that profile under general anesthesia, meaning putting them completely to sleep and on a ventilator, carries significant risk.
Because general anesthesia brings risks of aspiration, pneumonia, blood clots, or dangerous drops in blood pressure for older patients.
Exactly. So the doctors decided to do this under local anesthesia.
Meaning this man was going to be completely awake.
Fully awake. They opted for a local anesthetic approach. They set the CO2 laser to a continuous pulse, running at about 5 to 8 watts of power. And they meticulously shaved that lemon-sized mass down to normal skin while he sat there conscious.
Wait, hold on. You're telling me a doctor is firing a high-powered 8-watt surgical laser directly at this man's nose, vaporizing his flesh, and he is just sitting there awake?
Yep.
How does someone not panic or feel agonizing pain? I mean, just the smell of the tissue vaporizing alone must be overwhelming.
I know. It is a terrifying concept until you understand the brilliance of the anesthesia technique used here.
Okay, explain that to me.
They utilize a combination of a nasal ring block and tumescent anesthesia. First, they inject a numbing agent in a complete ring around the base of the nose.
Like a circle around it.
Yes. This intercepts and blocks all the major nerve signals traveling from the nose to the brain.
It essentially unplugs the nose from the nervous system.
Exactly. Then comes the tumescent part. They inject a large volume of dilute lidocaine mixed with epinephrine directly into the mass itself.
What does that do?
The fluid physically inflates the tissue, making it firm and rigid. This creates a much better surface for the laser to hit.
Ah, I see.
And simultaneously, the epinephrine strongly constricts the blood vessels, shrinking them down to prevent any lingering bleeding. Once that fluid sets in, the nose is completely dead to sensation.
Wow.
The patient feels some pressure, perhaps hears the crackle of the laser, but there's absolutely zero pain.
That is wild, and the outcome for this patient is stunning. The sources note he healed beautifully. But here is the crazy part to me. He didn't need a skin graft.
Nope.
They just vaporized half an inch of tissue off his face, and they just put moist dressings on it. How does the skin grow back?
It heals through a process called secondary intention. Because the laser doesn't destroy the deepest layers of the skin, where the hair follicles and the base of the oil glands live, those deep structures actually act as biological seeds.
Oh, that's fascinating.
Over the course of about 30 days, new, healthy skin cells migrate up from those deep follicles and repopulate the entire surface. 1 year later, this patient had no recurrence, no sick scarring, just a normal functioning nose.
It is a profound medical triumph, but thinking through the mechanics of this procedure brings up a massive hidden variable.
Let's hear it.
So the patient is 67 years old. He's awake. He's likely receiving some supplemental oxygen to keep him comfortable, right?
Almost certainly.
You're firing a laser that hits temperatures high enough to boil cellular water, and you're firing it inches from where he is breathing oxygen. Doesn't extreme heat plus pure oxygen right on the face equal a severe fire hazard?
It absolutely does, and you've just highlighted one of the most critical high-stress risks in any surgical environment.
It sounds terrifying.
It is. When you mix lasers and airways, the operating room protocols shift into maximum security. This is where the surgical fire safety training manual from our sources becomes highly relevant.
Okay, let's get into that manual.
To understand the danger, the surgical safety manual talks about the fire triad. For a fire to ignite, you need 3 specific elements to converge at the exact same moment.
Like a recipe for disaster.
Exactly. You need an ignition source, an oxidizer, and fuel. If you possess all 3 in close proximity, combustion is almost inevitable.
Okay, let's break those down. In our Rhinophyma scenario, the ignition source is pretty obvious. It's the CO2 laser. Or I guess in other surgeries, it could be the electrocautery tool or even the fiber optic light cables surgeons use.
Correct. Those cables can get incredibly hot if left resting on a drape.
Makes sense.
The second element is the oxidizer. In our everyday environment, the air we breathe is roughly 21% oxygen. But in an operating room, patients are frequently administered supplemental oxygen, medical air, or nitrous oxide.
Which creates an oxygen-enriched environment.
Right. And while oxygen itself isn't flammable, it acts as an extreme catalyst. It lowers the ignition temperature of surrounding materials and causes them to burn incredibly hot and incredibly fast.
And the final piece is the fuel. What is actually catching fire? I mean, in a surgical setting, fuel is kind of everywhere, isn't it?
It really is.
It's the sterile surgical drapes covering the patient. It's the alcohol-based skin preps used to clean the skin before the first cut. It's the patient's own facial hair or eyelashes. And crucially, it's the plastic breathing tubes delivering the oxygen.
Now, surgical fires are relatively rare, but they are uniquely catastrophic. The safety manual provides a truly jarring statistic. 44% of all surgical fires happen on the head, neck, and chest.
You're right, in the immediate vicinity of the patient's face and airway.
And even more terrifying, 21% of surgical fires happen inside the patient's airway itself.
Inside the airway. That is, wow, it's literally like building a campfire directly on someone's face.
That's a grim way to look at it, but
Yeah, you have your kindling laid out, the surgical drapes, the plastic oxygen tubes, the facial hair. You have a massive gust of wind blowing in to stoke the flames. That's the pure supplemental oxygen being pumped into the mask. And the surgeon is standing right there, holding the lit match, the laser. One tiny spark, one errant reflection of the laser beam off a metal instrument, and the entire setup combusts.
it is the definition of a perfect storm. So the entire choreography of the operating room is designed to systematically dismantle that fire triad.
How so?
Every single action the surgical team takes is about deliberately keeping the match, the wind, and the kindling separated.
Okay, how do they actually do that in practice?
Let's look at the standard protocols. To eliminate the fuel variable, if they use an alcohol-based prep to sterilize the skin, they are required to wait until it is completely dry.
So no wet alcohol fumes.
Exactly. If it's even slightly wet, the alcohol vapors can pool underneath the surgical drapes. A single laser spark hits that vapor and it flashes into a fire.
That's scary.
They also physically isolate the laser from any flammable material by covering the patient's face and hair in wet towels or wet gauze. Because simply put, wet cotton will not ignite.
Okay, and for the oxidizer,
The manual dictates strict limits there too. Anesthesiologists are advised to keep supplemental oxygen below 30% whenever possible if a laser is in use.
Got it.
Furthermore, they completely ban the use of nitrous oxide during high-risk airway cases. Nitrous oxide actually decomposes under high heat and feeds a fire just as aggressively as pure oxygen does.
So the golden rule of laser safety is basically keep the oxygen concentration as low as humanly possible, keep all the drapes wet, and make sure the alcohol is totally dry.
That's the baseline, yes.
Which makes perfect logical sense. But as I was reading through the sources, I hit a massive contradiction, like a glaring one.
I know exactly what you're going to say, the TH-RIVE study.
The TH-RIVE study. This Australian clinical trial completely breaks the golden rule we just talked about.
It really seems to, yeah.
This study looked at a technique called TH-RIVE, which stands for Transnasal Humidified Rapid Insufflation Ventilatory Exchange.
That is a mouthful.
Right. But the doctors in this study were performing laryngeal surgery, meaning they were firing a CO2 laser deep inside the patient's throat to remove tumors or lesions on the vocal cords.
Very delicate area.
Extremely. And while they were firing that laser, they were pumping 100% pure oxygen into the patient's nose at massive flow rates.
Huge amounts.
We are talking 70 liters per minute of pure oxygen blowing directly past the surgical site. So if the safety manual says to keep oxygen below 30%, and these doctors are blasting a hurricane of 100% pure oxygen right next to a firing laser, why didn't all 106 patients in that study catch fire?
It seems incredibly reckless until you dive into the fluid dynamics and the brilliant physics of how the TH-RIVE system actually works.
Okay, lay some physics on me.
Let's go back to the fire triad. Ignition, oxidizer, fuel. The doctors in the TH-RIVE study realized they could push the oxygen to the absolute maximum if they did one radical thing. Completely eliminate the primary fuel source.
Which in airway surgery is the endotracheal tube, the plastic pipe going down the throat.
Precisely. In a standard airway surgery, the patient is intubated. There is a plastic tube sitting right next to the vocal cords. Plastic is a highly combustible fuel.
Naturally.
If an 8-watt laser hits a plastic tube in an oxygen-rich environment, that tube melts and catches fire like a blowtorch inside the throat.
Oh my God.
But the TH-RIVE technique allows the anesthesiologist to oxygenate the patient without intubating them. There is no airway device in the throat at all.
So what do they use?
They just use high-flow nasal cannulas, little prongs sitting just inside the nose. By removing the plastic tube, they remove the most dangerous fuel from the triad.
Okay, the plastic is gone, but human tissue is still fuel, right? Fat and proteins can burn, and you are still blasting 70 liters of pure oxygen per minute down their throat.
True, but this is where the fluid dynamics get truly fascinating. That massive flow rate of 70 liters per minute actually works to protect the patient.
How does that work?
When you pump gas at that velocity through the nasal passages, it creates an enormous amount of turbulence in the airway. The air is swirling violently.
Okay, I'm picturing a tornado in there.
Sort of, yeah. Because the surgeon is operating through the mouth, meaning the patient's mouth is propped wide open, that internal turbulence creates a Venturi effect.
What's that?
The high-speed oxygen rushing down the nose actually pulls ambient room air in through the open mouth.
Ah, and room air is only 21% oxygen.
Exactly. The violent swirling actively mixes the pure oxygen from the nose with room air from the mouth. So even though the machine is pumping 100% oxygen, by the time that gas reaches the glottis, the exact spot where the laser is firing, it has been heavily diluted.
That is so clever.
The effective oxygen concentration at the tissue level drops dramatically well below the dangerous threshold.
So they removed the plastic tube and they weaponized turbulence to dilute the oxygen.
Essentially, yes.
But what about the smoke? Because earlier we talked about how vaporizing tissue creates smoke.
Right, the medical term is laser plume, but surgical teams often just call it laser smog.
Laser smog.
Yeah. When the laser boils the water in the cells, it also aerosolizes microscopic particles of fat, protein, and carbon. That smog isn't just an inhalation hazard. It is highly combustible.
So it's basically an aerosolized fuel cloud sitting in the airway.
Precisely. To manage this, the surgical teams aggressively deploy smoke evacuators. These are highly specialized, high-powered vacuums placed right next to the surgical site.
So they just suck it up.
The second the laser creates a puff of smoke, the vacuum sucks it out of the airway before it can even accumulate and ignite.
Okay, so no plastic tube, diluted oxygen via turbulence, and vacuuming up the combustible smoke. They controlled the fuel and the oxidizer. Did they do anything to mitigate the laser itself, like the ignition source?
They absolutely did. They relied on a principle called thermal relaxation time.
Thermal relaxation time, what is that?
If you hold a laser on a single spot of tissue for too long, the heat builds up and spreads to the surrounding area, which increases the risk of ignition.
Right, that makes sense.
In the TH-RIVE study, the surgeons kept the laser power incredibly low. The average power used was only 4.3 watts. More importantly, they never fired it continuously.
So they pulsed it.
Yes. They used short, precise pulses, ensuring they never fired the laser for more than 10 seconds at a time. This gave the tissue time to cool down between strikes.
Wow. And the result of all this invisible, high-stakes choreography? 0 airway fires in 106 procedures. 0. They took a scenario that looks mathematically guaranteed to start a fire, and through applied physics and fluid dynamics, they made it completely safe.
It is a masterclass in risk management. It really proves that even the most inherently dangerous environments can be navigated safely if you systematically break down the mechanics of the risk and control the variables one by one.
It has been an incredible journey today. We started by looking at Rhinophyma, a severe condition that causes intense physical deformities and emotional suffering, often exacerbated by cruel historical myths.
Yeah, that part is really tough to hear about.
It is. We learned how doctors are utilizing the specific physics of cellular water and the precise wavelengths of CO2 and erbium YAG lasers to basically vaporize that disease away.
A literal magic wand.
They can literally sculpt a patient's face back to normal, offering a total reset on their confidence and their ability to breathe, all while the patient sits there wide awake.
And then we explored the shadow side of that medical miracle. We dissected the fire triad and saw how the simple combination of a laser beam, supplemental oxygen, and everyday surgical materials can create a deadly scenario.
Such a delicate balance.
But more importantly, we saw the rigorous, brilliant protocols surgical teams use every single day to dismantle that risk and keep patients safe.
Which brings me to a final thought to ponder. In the TH-RIVE study, doctors did what many considered impossible. They mixed a hurricane of pure oxygen with a surgical laser inside a human airway.
Defying all the conventional wisdom.
Right, but they made it safe simply by eliminating one crucial variable. They took out the plastic tube.
It's amazing when you think about it like that.
It really makes you wonder about the roadblocks in our own lives or industries. What other seemingly impossible challenges or dangerous combinations could become perfectly safe breakthroughs if you just figured out which single variable to remove from the equation?
That's a great perspective.
The next time you find yourself staring at an impossible problem, Maybe the answer isn't learning how to fight the fire. Maybe the answer is asking yourself, where is the plastic tube and how can I take it out?
A phenomenal question to leave on.
Thanks for joining us for this deep dive. Until next time.